is Sarah Sieper, and I'm the Knowledge Management and Strategic Communication Senior Associate on the Momentum Integrated Health Resilience Project funded by USAID. Today we have Dr. Etta Mbong-Ngole, Chief of Party for Democratic Republic of Congo, MHR program, to discuss his experience as the COP supporting a project that operates at the Humanitarian and Development Assistance Nexus, and to share some insights as to how the project adapted and leveraged various assessment tools to better understand how conflicts, disasters, and other shocks and stresses impact health systems and services, as well as the health of households and communities. Dr. Etta, can you go ahead and introduce yourself, specifically a little bit about your background and experience, as well as your role on Momentum?
Thank you, Sarah. So I am Dr. Etta Mbong-Ngole. I'm a physician and public health specialist. Currently, I work with, I serve in the Democratic Republic of Congo, or what people often call the DRC, as a Chief of Party or Project Lead for Momentum Integrated Health Resilience, which is one of the Momentum awards funded by USAID. With the aim of accelerating reductions in maternal, newborn, and child deaths, as well as improving access to sexual and reproductive health services and health in adolescents. My background, prior to working with MHR, I have worked in several sub-Saharan countries on development as well as humanitarian projects. My career started with development projects, and then were like projects in peace times, and then later on moved to humanitarian projects in shock-prone settings. Yeah. Over.
I want to touch on your experience as the COP and, how it's been different maybe than other global health programs you've worked on before, specifically in terms of working at the intersection of humanitarian and development nexus. And for those that are unfamiliar, the humanitarian development nexus is a collaborative approach to connecting humanitarian and longer-term development efforts to really be able to achieve collective outcomes for those affected by crisis, like the fragile settings in which Momentum works.
Thanks. So, how is MHR or Momentum Integrated Health Resilience different from the other projects I've worked in? Is that most of the other projects I've worked in is they are actually purely development, or should I say entirely humanitarian projects. Of course, those projects would often also collaborated with, if it's a humanitarian project, with development actors, or vice versa. But what's peculiar about MHR is that it's not just about coordination of action between, let's say, humanitarian project and development actors, but MHR as a development project works along with humanitarian projects to ensure that while humanitarian actors are ensuring that people have, let's say, access to relief items, that access to services which normally health facilities or community care sites should be providing in times of peace continue. Let me give a typical example. For example, if, for example, there is an outbreak of, let's say, like we have now, mpox, the focus should not be just perhaps taking care of mpox clients, or patients who have monkeypox. But Momentum works with humanitarian projects to ensure that other essential health services which were there before the monkeypox, for example, vaccination of under 5 children who are aged less than 5, antenatal care for pregnant women, postnatal care for women after delivery, or let's say access to not just that access to somebody who has let's say has a chronic disease continues, and then also access to sexual and reproductive health services continue alongside the delivery of support for relief, either in terms of water or food items or non-food items. So that's one of the peculiarities of momentum integrated health resilience, unlike other projects which I've worked in. Another thing which makes MIHR special compared to other projects I've worked in is that MIHR helps health facilities to develop preparedness plans, which include aspects about service continuity. Often most preparedness plans which I have seen on projects I've worked which in have developed, they are entirely preparedness plans to, for example, to help a health facility or a community or a health district to respond to a shock with specific interventions for relief. But with MIHR, MIHR's approach is that the preparedness plan is a holistic one, not just to include specific interventions to provide relief items, but or specific to a shock, but also, as I mentioned, to ensure that the delivery of essential health services continues during the shock. So it's a more holistic preparedness plan, a more complete plan. So those are two examples which I can give about how MIHR is different compared to other projects and initiatives I've worked in the past and which I know about, which work in the humanitarian development sectors.
Great, thank you so much. Those examples were very helpful. Not just focusing on the crisis at hand, but making sure that we're taking care of the aftermath as well as, preparing for, an inevitable situation of it maybe happening again, making sure that the communities and the health system is prepared to respond sort of in a better way than they've done in the past. So thank you for that. Moving on to the DRC country program specifically, could you provide a bit of an overview of the program? As you mentioned earlier, MIHR's sort of overarching goal really focuses on strengthening resilience and providing high quality, respectful maternal, newborn, and child health, voluntary family planning, reproductive health. So what are some of the key priorities of the DRC's program specifically, and maybe some of the activities that might be unique to your country compared to other countries within the Momentum Project?
Yeah, so perhaps permit me begin by how MIHR started in the DRC. That was at the end of between 2019 and 2020. DRC was just recovering from its 10th Ebola outbreak, which was the worst in the country's history and the second largest Ebola outbreak that the world had experienced. I had just arrived at DRC and I was part of the Ebola response. What we noticed was that during that period of the Ebola response, every bleeding was considered a case of Ebola. Let me give an example. If a lady of reproductive age or a young girl came, a young adolescent girl came to a health facility with a bleeding, the first thing our first referral would say, no, this is a case of Ebola. So she is isolated, and until you get the Ebola test, what we call the PCR, the viral test. But we forget that as someone of reproductive age, as a young adolescent, she may be pregnant, it may be a pregnancy, and it may be a threatened miscarriage or a threatened abortion, will come or miscarriage she's having. So the reflex was that we're so focused on on controlling this very deadly Ebola outbreak, which took over 2 years to control, and which everyone knows it has a very high case fatality, that we forgot that there are other essential health services which a young girl or a woman of reproductive age would need. Also, during that period, I remember the very limited resources which we had in the DRC, either in terms of human resources or in terms of health facility space to take care of. It was this way used to take care of Ebola cases. And at that time, because of incentives and support we provided to either community health workers or community health healthcare workers were supporting the Ebola response, it made that all healthcare workers or community health volunteers wanted to be part of the Ebola response. So very few were willing to, for example, continue providing routine vaccines to children or to pregnant women, or let's also, for example, for example, somebody has malaria or some other chronic disease like diabetes or hypertension, to provide those routine essential health services. So the focus was so much on that. So what happened was that during those 2 years, but of course it was a very deadly disease. So what happened was that though there were lots of talk about how many people died of Ebola, but also there were lots of deaths from preventable and other endemic diseases. And also at that time, it impacted routine services like routine immunization and antenatal coverage. So, however, all actors, frontline actors, realized the mistake we're doing, that we're focusing so much on the response and forgetting endemic diseases, which were the other essential health services. So towards the end, after 2 years, we're trying to catch up. So with the support of USAID, we received IMA World Health and some other organizations were asked to form part of the MIHR consortium and then begin supporting the Ministry of Health to restore essential health services, and also as part of what we call a post-Ebola transition plan. So that's how MIHR started. So the first 2 years, we had to invest in ensuring that working with humanitarian actors who were responding to Ebola to be able to help the government to manage its resources and now think about other essential services like routine immunization, antenatal care for pregnant women, and also people who have other endemic or chronic diseases. Being a project that seeks to accelerate reductions in deaths and also illnesses in women, newborns, and children, our focus, like all MIHR countries, is on maternal newborn child health, and then also improving access to sexual reproductive services, as well as family planning, and also improving adolescent health. However, unlike some other MIHR countries, we were one of the few countries which received additional funds to be able to, because immediately after the Ebola outbreak, then came the COVID pandemic. We're able to, in addition to supporting maternal, newborn, and child health, adolescent and sexual reproductive health, to support now for the last 3 years the Ministry of Health to be able to control the COVID-19 pandemic based on Ebola response, including through the rollout of COVID-19 vaccines. So MIHR was one of the few projects was supporting the Ministry of Health, which I've been supporting for the last 3 years, the Ministry of Health, to be able to roll out COVID-19 vaccines, to be able to include reduce support to reduce vaccine hesitancy and then vaccine uptake. And since 1 year, given that when COVID-19 started, was done in a parallel manner. So you had routine immunization services and they had COVID. For the last about 9 months, MIHR is amongst one of the few partners, unlike other countries, MIHR countries, it's amongst one of the few actors who is supporting the Ministry of Health to integrate COVID-19 vaccination into routine immunization services. As I say, it's the same resources, the same health facilities, same health workers. So to be more efficient in the use of the limited resources, now we have been for the last 9 months supporting the Ministry of Health to get the same services which deliver routine vaccine for children and other adults to be able to also administer COVID-19. Another thing which I should say difference about MIHR, the DRC, and other countries where it is implemented is that MIHR is one of the few countries where we have been able to test many of the tools which MIHR project has developed or either adapted to better understand how shocks impact communities or different parts of the health system, and to be able to use the information to be able to work with other partners to strengthen the health system. Then last, perhaps another difference that we also received some additional funds as part of to support the Ministry of Health to be able to reduce acute malnutrition in North Kivu caused by the global disruptions in food supply chains associated with the war in Ukraine, as well as other shocks. So with that money, we're able to support some families to be able to set up kitchen gardens, which also has helped them to have at their doorstep nutritious food and not depend on markets where the prices of essential commodities like even seeds have risen. So I think those are some of the interventions which have been implemented successfully in the DRC, unlike other emerging countries. Thank you.
Great, thank you for that. I was hoping that you'd sort of, mention the COVID pandemic as well, because as you were talking about, the Ebola outbreak and how DRC sort of got introduced to MIHR, I was just thinking, how important it is to really focus on, health system strengthening, because inevitably, things like this happen over and over again. And, while they're not always preventable, what we can do is be better prepared for them when they come the next time. So exactly like what you were saying, where now your response to the COVID pandemic was probably a lot more robust than maybe it would have been if you hadn't just experienced for the last 2 years sort of putting together in place a plan to respond to the Ebola crisis as well. And something else that you mentioned, sort of the tools that are being used in the DRC. So I know you guys do the health facility assessment, or the HFA, and the recurrent monitoring system, or RMS, both really looking to measure the ability of health systems, individuals, and households to be able to respond, to these shocks and stresses. Can you talk a bit about each of the tools and sort of, maybe share how they're different, and how you guys use them in the DRC?
Yeah, thanks. So, being a project which has as goal, in addition to improving maternal, newborn, and child health outcomes, given that MIHR also seeks to strengthen the resilience to shock of the health system, it was important that we understand the impact of shocks on different parts of or different levels of the health system. So with the support of the team, MIHR team at HQ, we're able to identify existing tools, some existing tools, and then where there were no existing tools, to be able to also to develop tools from the scratch to be able to identify or document shock, and then to be able to understand at different level of the health system, as I mentioned, how they affect either access to health services or health seeking behavior, and how to understand how people adapt during those periods, how people cope during those periods. So two of the tools of those tools are the, as you mentioned, the health facility assessment, and then the recurrent monitoring system, or the RMS. The first one, health facilities, or the HFA. So the HFA and the RMS, or should I say, were existing tools which MIHR adapted. In the case of the HFA is a health facility assessment. So it is typically used by either development or humanitarian actors to be able to understand the readiness of a health facility to be able to deliver essential health services. However, what often most of the HFAs lack is that they don't have they miss. They are good for example, understanding readiness in times of peace or when there are no shocks. But often when you start implementing a project and then there will be a shock, and all the information you had got from the baseline using a typical HFA, then you have to now learn and adapt and the information is no longer valid because you didn't take into consideration that it's an open system and there might be shocks. So what MIHR did with the MIHR adapted health facility assessment is that we added a module on health facility preparedness and the impact of shocks on their capacity and their ability to provide health services. So that model added has helped us to not only understand their ability to be able to provide health services essentially during normal times, but to be able to understand also the impact of what are the common shocks in the different communities where the different communities in which you support a health facility, what are the common shocks, how the shocks affect service delivery, also how the health facility adapts to be able to continue providing services. And also one important question in that model is to know if the health facility has a preparedness plan to be able to continue providing services during those times. And if not, and if yes, how good is the plan? And if not, what the impact of having such a plan can be. That's for the HFA. In the case of the recurrent monitoring survey, the aim, it was also, it's a tool. The recurrent monitoring used to be survey with nice-down system or RMS. It is a tool which had been used in the past, unlike the HFA, which was health. A health tool. The RMS is a tool that has been used previously in the past for food security systems to be able to understand the impact on food security of shocks. But the MIHR adapted our health RMS, we call it the health RMS. It's the first time we are aware of the recurrent monitoring system being used to understand how shocks impact at the household level, access to health services, and how health-seeking behavior during those periods and how people adapt during those periods and how they cope. So those are the two tools. So one, the HFA, both, of course, seek their adapted tools and they seek to help us better understand the impact of shocks. But one is the HFAs at the health facility level, while the recurrent monitoring system is at the household level. That way you have a more holistic picture of how shocks impact health systems or different levels of the health system, health-seeking behavior, as well as the delivery of health services. And how prepared people are to either to absorb such shocks, adapt, and to continue accessing health services during those periods.
Thank you for that. I'm interested to know, once you collected and analyzed the data from these tools, what were some of the overarching findings that, might be interested to share? And, how did your country team, leverage these findings from the assessments and then, maybe implement some programmatic changes just based on what you were seeing from these assessments?
Thank you. So in the case of the HFA, the MIHR adapted health facility assessment, there was this question which we asked for each health facility. We wanted to know during the year prior to the survey if they had experienced any shock of any kind. Here, the definition of shock is an acute event, unexpected event, which would cause a disruption in either the ability to provide health services or to receive clients, or which can even go like to, no matter how short it is, which can even lead to, let's say, the health facility being temporarily closed. So one of the questions we asked was if they had experienced a shock the year prior to the survey, and it was interesting to note that almost all the health facilities, not almost all, 4 of every 5, well, that's a lot. 4 of every 5 knowledge during the year prior having experienced a shock. And in terms of the shock, the most common shock probably is because it's it's a characteristic of the North Kivu where the project is being implemented is a setting with protracted armed conflict. The most common shock was armed conflict, and then followed by outbreaks. And then also after outbreaks, you had a mass population displacements. So you had 4 of every 5 assessed health facilities had experienced a shock a year prior to the survey. But there was a question we asked, okay, amongst those 80% who had experienced a shock, how many of them had a preparedness plan? A plan to like some plan which they had agreed as a team to be able to, okay, in base when you have a shock, this is how we can ensure that the health facility doesn't shut down, or this is how we can reorganize ourselves, or these are alternatives we have to continue providing, ensuring that people can receive essential health services. And of the 80% who experienced a shock, less than a third had any preparedness or service continuity plan. The few that had the service continuity plan, there were lots of gaps. Let me give an example. Amongst the shock, also you had some which had experienced like a fire, a community fire that affected the health facilities, but most of the health facilities didn't even have a fire extinguisher. So there were things as basic. So you had, and then of course, another thing is that those who even had the plan, I think just less than 10% had prepositioned stocks. Prepositioned stocks, for example, if there's a flooding and then you can't, let's say, supplies are destroyed, or let's say you have an influx of people who need care, you need more supplies. But less than 10% had stocks which they had kept somewhere, which would be help them either manage if stocks are destroyed, they can use them as a buffer or a backup, or let's say if they have an increased demand, they can use it while they wait for extra stock to come. So less than 10% have preposition stocks, and these are amongst those who had a preparedness plan. So to summarize the HFA, what we discovered was that shocks were common. It's true they were diverse depending on the community. Some it was more flooding, some was fire, some was armed conflict. However, despite the fact that the shocks were common, very few had preparedness or service continuity plans. And even when those plans were there, really the plans had lots of gaps. I remember there was a question which we asked about how many health facilities had like summaries or like key actions of those plans put up in key areas of the health facilities, and less than 20% had that put up. Meaning that those who even the few that had plans, the plans were in some drawer or in some laptop, some person's drawer or some person's laptop. And of course, when you don't have, there's a plan, but not everyone is aware of it. And with high staff turnover, what happens is that, okay, it's not a plan. It's not, we were able to operationalize it because not many people. So even awareness about the plan was an issue. In the case, what we did was that, what we have done is that since last year, after the results, after this really very sad findings, what MHR has done in North Kivu is that we have started supporting health facilities to develop preparedness and response plans. I just want to highlight that in the past, the health facilities which had the few that had preparedness plans, the plans were, as I say, it's a typical plan. The focus is on responding to, let's say, if there's an outbreak, caring for, let's say, measles outbreak, caring for measles cases. The plans don't have a component or a subcomponent to continue of which outlines strategies to continue providing other essential health services. So the preparedness plans that MIHR has helped supported, I began supporting health facilities to develop is a holistic one. So you have a component for if you want to provide shock-specific actions, if it's, let's say, measles or cholera, of course, there are specific intervention for cholera patient, or the flooding, or it's a fire, or it's conflict, and then you have casualties, wounded people. But then again, in those plans, we have agreed, worked with the health facilities, and they have agreed as a team how to, so you have the service continuity component, whereby it outlines like some key actions, how the health facility can reorganize itself, mobilize surge capacity, preposition stock, as well as train health care workers, as well as community health volunteers to be able to ensure that when you have those shocks in addition to interventions specific to respond to the shock, other essential health services like routine immunization, antenatal care, care for persons with chronic disease can continue. In the case of the RMS, the recurrent monitoring survey, at the household level, one of the things we discovered was quite surprising for us was that though most of the communities are communities where you have like armed conflict, escalations of protracted armed conflict, the most common shock health facility, households reported months before having experienced months before the survey was rising food prices, food insecurity. And not that was a surprise, with the impact of the COVID pandemic on the global supply chain, post-COVID, the restrictions, there was it impacted food supply chains, global supply chains in general, including those of food. And as I mentioned, those communities that had just come out from an Ebola outbreak, and they had a COVID pandemic. And then, of course, you had the war in Ukraine with the also the disruptions in terms of like wheat and all of that. So it was a little bit, we were expecting that it should be more of like armed conflict, but the families were more concerned about having food on the table, how costly things are becoming in the market. And it also makes sense because when you have conflict, people can't farm. And when people can't farm, people flee. What happens is that, of course, land for farming is occupied for, let's say, it's either as a battleground, or so it makes that it also has an impact on food security. So what MIHR did was that based on that, well, there were other shocks which they experienced as well. Conflict was also one of them, but the highest, half of the families. So 1 of every 2 family reported that was the most common shock. Inflation in food prices and rise in food insecurity. So what MIHR did was that thanks to additional funds we received from USAID, we're able to identify families whom we provided seeds as well as farming tools. And then we mobilized local agriculture extension workers from the local Ministry of Agriculture who helped those families to set up nurseries. Actually, what we said, there were some families, there were family nurseries, and then there were also community nurseries, where it was a community nursery where the seeds were nursed, and then families came and then took the sprouts, and then they set up their kitchen garden. As I mentioned earlier, in response to one of the answers, it has helped families now to, rather than depending on the market, essentially on the market for food, they can have nutritious food at their doorstep. So we have supported 2 cohorts of families. The first cohort was supported during the 3rd year of MIHR's program. That was in 2023, and the second cohort this year, 2024. We haven't really assessed the impact of it, but we did an assessment, and what happened, one of the questions we asked families is that on a scale of 1 to 10, how has the kitchen garden like an outcome has it helped you to able to maintain access to nutrition from a scale of 1 to 10, and the average score families gave was 8. So that's encouraging, that kitchen garden, of course. And one of the questions we asked them was, okay, how do you do? Is part of the produce sold? What's part of the harvest sold? And some families, about a third of the families said they sold some of the harvest. And one of the questions I asked them, okay, what did you do with what you got the money from? And it was interesting what the answer they gave was that money they got there, they used it to buy other seeds which the MIHR project didn't provide. So it was interesting to see, because it was one of our learning questions to know the impact. Would the kitchen garden be used by full harvest be used by the family, or would it be sold for money? And then perhaps they use it for the child's education or something else. But what's interesting is that the most common use of the money was to reinvest in the garden, which was quite interesting. Question. So that's how we used. That's an example how we used one of the example how we used the findings of the recurrent monitoring system to be able to strengthen access to nutritious food through kitchen gardens. Thank you.
Thank you for that. I think both examples are really great. And it seems like the country team has really learned so much from these assessments. And I think a huge part of that too is also, the work that you did up front to adapt these tools for your setting. I think that also probably generated even more useful responses than maybe if you had just used sort of more standard tools that were not developed for the DRC context and didn't include that sort of resilience and preparedness and system strengthening sort of aspect of that. So it's really great to hear. I want to end our interview with this question. So, for global health professionals out there, or those working in adjacent fields that may support programs where there's frequent conflict and shocks and stresses as well, that may also impact program implementation, what's some advice that you can offer them from your experience working on MAHR and all the great things that the DRC program has really been able to achieve over the last couple of years?
For the question. Compared to other projects where I've worked in the past and which have been in volatile settings, most projects didn't have tools like to be able to understand their context, the context in which they are working in, and also to be able to understand how that context impacts, let's say, their plans or their beneficiary structures or beneficiary communities. And also not to talk about tools that to understand how shocks impact access to services they wish to provide. So what first advice I would give is that I will give, based on my experience with MIHR, is that when one works in a very a setting that is quite volatile, which changes very often, it will be interesting to not just rely on baseline information or the information which you use to develop the project or the intervention, but also to have a system in place whereby which would include tools as well as processes to be able to understand, check the context regularly, and to understand how it has changed and how to adapt your intervention or support you're providing to either communities or families or structures you are supporting. And you don't have to invent the wheel or to reinvent the wheel. You have tools which projects like MIHR has developed if it's in the domain of health. And then in the domain of other, like food security, there are other groups which are projects and organizations who are doing a lot of work developing tools. So you just have to look for the tools, and you'll be able to find it. So to say that rather than just depending on information which I had before the project or at the baseline, you'll be able to have tools which help you understand the context, the impact of shocks, how they, Second advice, which I think I would give, is that we have to invest in preparedness. Most donors would either fund, and I know that many organizations would either invest in either humanitarian work or development work. That preparedness like this, should I say, okay, it's like this gray area, which, or that area in the middle, which nobody wants to, some donors, many donors, few donors fund it. And as a result, many organizations will invest in it. But I think it's very important, especially during the peace times. So in trying to, especially for development projects we saw what happened with COVID-19, even countries which had very strong systems collapsed or collapsed during the COVID period. So strengthening a system or a health system is not enough. What we have to do is that we should be able to strengthen not like the system to make it in like a brick, like bricks which you use to make the wall, but rather we should be able to have a system which is strengthening in such a way that it's a spring, meaning that when there is a shock, it can bounce back. So our goals should not just be typically health system strengthening, but also resilience strengthening, especially as with the climate change and the world now you have shocks which are even more. So we should invest not just in projects which just strengthen the health system, making it like a brick or a block to build a wall, but also, as I mentioned, to be able to make it resilient. And I think that there are many donors now have been interested. So I think other organizations or actors should be able to look for those donors who wish not to invest in system strengthening, but in typical system strengthening, but also in resilience strengthening. Another advice I was talking about preparedness, perhaps if I get back to it, is that as part of the building back better, or let's say as part of the development process, I think we also should be humble to say that, okay, this system I've built might have to withstand a shock, meaning that also we have to invest in preparedness actions. So preparedness actions, which will say, okay, this is my plan A, this is my plan, but it might happen that things don't go the way. So how do I prepare in such a way that should, in case things don't go that way, the system I've built, it will be able to absorb the shock, adapt, perhaps for some time struggle, but later on find a way to get back to my initial plan A. So if I want to summarize, so say first, having system processes and tools to be able to understand your context and shocks, how they affect, to be able to better build your system. Secondly, investing in preparedness, given that you never know what's going to happen. Preparedness so as to be able to, your system which you have built can easily adapt. And then as I mentioned, looking for donors and interventions. We do not just build bricks of a system made up of bricks, but a system which is like, how can I say, springs, which can withstand shock, absorb them, and then bounce back better. So I think those are the three advice I can give to persons and organizations working in similar settings like DRC I work. Over.
Thank you so much, Dr. Etta, for your insight and for sharing your knowledge and your experience related to, programmatic implementation and the adoptions in the face of conflict and stress. Thank you so much for joining us today.
Thank you, Sarah, for your time as well as for the interest you have in what I do and what MIHR does in the DRC.